Cerebral Folate Deficiency Syndrome, or CFDS, often shows metabolic psychiatric symptoms early in childhood. But even in adulthood, it can still be diagnosed and treated. CFDS can look very different from one person to another. Symptoms may include developmental delay, seizures, ataxia, cognitive impairment, and more. And because these signs can closely resemble more common neuropsychiatric conditions like autism spectrum disorder or schizophrenia, CFDS is often misdiagnosed. When the brain doesn't have enough folate, the nervous system can be seriously affected. That disruption can lead to a range of psychiatric and behavioral symptoms. The good news is that with timely testing, such as metabolic and biochemical screening, along with genetic testing and treatment with Leucovorin calcium, folinic acid, many patients can see significant improvement and a much better quality of life. In today's video, we'll walk through real patient cases to take a closer look at how CFDS develops, how it's diagnosed and treated, and what outcomes can look like after treatment. 1. Clinical features of Cerebral Folate Deficiency Syndrome. CFDS. Cerebral Folate Deficiency Syndrome, often shortened to CFDS, is a very unique condition. The key feature is this: blood folate levels can be normal, but the brain is still severely low on folate, especially 5-methyl tetrahydrofolate, or 5-MTHF. That lack of folate directly disrupts brain function and can lead to a wide range of neurological and psychiatric symptoms. These may include developmental delay, seizures, autism-like features, ataxia, cognitive decline, low muscle tone, and even ADHD. CFDS symptoms can show up at different ages. Let's break down what it can look like across stages of life. Infancy, around 4 to 6 months. The earliest signs are often related to the brain still developing. A baby may become unusually irritable, sleep poorly, have feeding difficulties, and sometimes show slower head growth. You might also notice low muscle tone and early problems with coordination. These signs can appear very early, but they're often mistaken for general developmental delay or even digestive issues. Late infancy to toddler years, 6 months to 2 years. In this stage, motor delays often become more obvious. Milestones like sitting, crawling, and walking may happen later than expected. Seizures, ataxia, and poor coordination can also appear. And in some cases, a child may lose skills they had already gained. This age range is often when CFDS becomes most noticeable and most typical. Preschool to early school age, 2 to 6 years. As brain functions become more complex, children may develop language delays or even regression, along with social difficulties, attention problems, and behavioral changes. Many children show features seen on the autism spectrum, especially in cases linked to folate receptor autoantibodies. Late childhood to adolescence. If treatment is delayed or never started, cognitive abilities may gradually decline and emotions can become more unstable, including anxiety and depression. At the same time, ongoing ataxia and movement problems can interfere with daily life. Brain MRI may show white matter injury, including signs of a demyelination. Adulthood. In adults, CFDS may present as late-onset ataxia, and sometimes with psychiatric symptoms such as depression and cognitive impairment. And in patients with certain FOLR1 gene variants, imaging may show an atypical white matter disease pattern. 2. 5 possible mechanisms behind CFDS. Now let's talk about 5 major mechanisms that may contribute to CFD, so you can better understand how CFD affects the brain. First, folate can't enter the brain properly. Normally, folate enters the brain through the blood-brain barrier, but when something disrupts that transport, the brain may still end up folate deficient, even if blood folate looks normal. One common issue involves the folate receptor alpha, or FR alpha. In some cases, the immune system can attack this receptor, making it much harder for folate to get into the brain. When folate can't reach the brain development and function are affected. This mechanism is often seen in immune-mediated cerebral folate deficiency, and it can contribute to neurodevelopmental delay, and in some cases, symptoms that resemble autism or even psychotic disorders. Second, not enough folate stored inside cells. Folate in the brain isn't just floating around. Neurons have a kind of internal storage system. They convert folate into more stable forms and store it inside the cell, almost like a small warehouse, so it can be released when needed to support critical brain functions. If that warehouse runs low, problems start to build. Neurotransmitter production can be disrupted, DNA repair becomes less efficient, and neurodevelopment can be affected, ultimately worsening CFDS symptoms. Third, the brain uses up reduced folate too quickly. The brain relies heavily on 5-MTHF, the reduced form of folate, to help make neurotransmitters and keep nerve cells functioning normally. If the brain's demand is unusually high, it may burn through folate faster than it can be supplied, leading to deficiency. Certain genetic conditions and some medications may increase folate demand or utilization in the brain. For example, some treatments used in Parkinson's disease have been discussed in this context. Fourth, increased breakdown of folate in the brain. It's not only about using folate, it's also about not breaking it down too quickly. In some diseases or under certain environmental stressors, folate may be degraded faster inside the brain, which lowers overall folate levels. One example is oxidative stress, which can become more severe in some conditions and speed up folate breakdown inside cells. Fifth, factors that disrupt folate metabolism in the brain. Finally, anything that interferes with folate metabolism can reduce the brain's ability to access usable folate. This includes certain inherited metabolic disorders, such as MTHFR deficiency, and also deficiencies of key vitamins like B2, B6, B9, and B12, all of which play roles in folate-related pathways. When these pathways are disrupted, the brain may not receive enough functional folate, and the nervous system can suffer as a result. So those are 5 potential mechanisms behind cerebral folate deficiency. They can overlap and interact, disrupting normal brain development and function, and leading to a wide range of neurological and psychiatric symptoms. And once you understand these mechanisms, it becomes much clearer why CFDS can have such a profound impact on a patient's daily life. 3. How CFDS leads to neuropsychiatric symptoms. Cerebral Folate Deficiency Syndrome, CFDS, can cause a wide and complex range of neuropsychiatric symptoms. And it all starts with one core problem. The brain isn't getting enough folate. First, low folate supply in the brain, the central issue. In the brain, 5-MTHF is the main form of folate that can be used effectively. So when 5-MTHF levels in the cerebrospinal fluid drop, the brain can't get enough folate to support basic metabolic processes. As a result, normal brain function is disrupted, and neuropsychiatric symptoms can begin to appear. Second, key brain functions that depend on folate start to break down. Inside the brain, 5-MTHF plays a critical role, especially in neurotransmitter production. It directly affects the synthesis of dopamine, serotonin, and norepinephrine. These neurotransmitters help regulate mood, behavior, and cognitive function. So, when 5-MTAF is low, neurotransmitter production can decrease, leading to mood symptoms like depression and anxiety, along with problems in attention, behavior, and overall cognition. Third, impaired neurodevelopment and myelination, structural brain effects. 5-MTHF is also essential for DNA synthesis and repair. It supports cell growth and is especially important for myelin formation. Without enough 5-MTHF, myelination can be disrupted. That can contribute to ataxia, poor motor coordination, and abnormal white matter development, affecting motor milestones and overall nervous system health. In some cases, it may also increase the risk of seizures and sensory symptoms. Fourth, sleep regulation and neural circuits for behavior become dysregulated. 5-MTHF doesn't just support metabolism, it also influences the brain's balance between excitation and inhibition. When folate is low, systems involving key neurotransmitters like GABA and glutamate can become imbalanced. That imbalance may lead to spasms, a lower seizure threshold, sleep disruption, and difficulty regulating emotions. This is why many people with CFDS experience restless sleep, irritability, and attention-related symptoms. Fifth, increased inflammation and oxidative stress. Folate is important for antioxidant balance and cellular repair. When 5-MTHF is deficient, it can contribute to neuroinflammation and increased oxidative stress, which further damages neurons. Mitochondrial function may also be affected. Over time, these changes can lead to chronic neurological injury, often closely linked to cognitive decline and behavioral changes. Overall, the mechanisms behind CFDS are complex, and they disrupt multiple critical brain functions. And those disruptions are exactly what drive the neuropsychiatric symptoms we see. Understanding these pathways helps us better explain what CFDS is doing to the brain, and it also points us toward more effective treatment strategies. 4. Real patient case. 2 siblings with CFDS. 1. The diagnostic journey of a brother and sister. Now I want to share a real-life case of 2 siblings. A story that's full of challenges, but also important lessons. This case was reported by the pediatric neurology team at West China Second University Hospital, Sichuan University, in China. The children's parents were not related. There was no notable family history, and for the first 3 years after birth, both kids seemed to develop normally. But over time, things began to change. Their development started to regress, and signs of neurological problems gradually appeared. The older brother, first labeled as developmental delay. When the brother was around 3 years old, he became unsteady and started falling frequently. Over time, he developed worsening problems with coordination. As symptoms progressed, his speech and motor abilities declined. He became less energetic and eventually showed low muscle tone as well. At first, the family believed it was just developmental delay. They tried rehabilitation therapies, but the improvement was limited. By age 8, he was having frequent seizures, and routine anti-seizure medications were not effective. The family returned for more testing. Brain imaging showed a typical pattern of delayed myelination, and the EEG showed multifocal epileptiform activity. The younger sister, regression with hyperactivity and cognitive decline. The sister's course was similar, but not identical. Around age 3, she began to regress more severely. Her walking became unstable, and she lost skills she had previously mastered. As symptoms worsened, her language abilities declined, and she developed signs of cognitive regression and hyperactivity. Even with anti-seizure treatment, her condition was not well controlled. The turning point, thinking about an inborn error of metabolism. At that point, doctors suspected an underlying inherited metabolic disorder, an IEM, and ordered genetic testing. The results showed that both siblings had a homozygous mutation in the FULR1 gene. At the same time, their cerebrospinal fluid 5-MTHF levels were significantly below the normal range. Together, these findings confirmed FOLR1-related cerebral folate transport deficiency, often described as FOLR1-CFTD, a form of CFDS. Clinical assessments showed differences, even with the same mutation. After diagnosis, both children were evaluated in detail. On cognitive testing, their scores were below 40, suggesting significant intellectual impairment. In daily life skills assessments, the brother needed some assistance, while the sister was fully dependent on others. Autism evaluations showed no autism symptoms in the brother, but the sister showed some autism-related features. What's especially important here is that even though they developed symptoms around the same age, their presentations were different. This suggests that a genetic variant alone doesn't fully predict the final clinical picture. Factors like overall genetic background, individual nutrition and diet, environment, and developmental differences may influence how symptoms appear and progress, possibly through epigenetic mechanisms. Treatment and recovery. Once the diagnosis was confirmed, doctors started Leucovorin calcium, folinic acid, right away, gradually increasing the dose early on. The response was striking. Both children had a clear reduction in seizure frequency, and their language and social skills improved. They still lagged behind peers, but their symptoms stabilized, and their quality of life improved significantly. Why this case matters. This story highlights how critical early diagnosis and treatment can be. At the beginning, the symptoms were relatively mild and not very specific. But with neurological exams, CSF testing, and genetic testing, the true diagnosis, CFDS, became clear. In this condition, FOLR1, mutations prevent folate from being transported efficiently into the brain, disrupting normal neurodevelopment and brain function. And because CFDS can look like more common conditions, such as autism, epilepsy, or other neuropsychiatric disorders, it's easy to miss. So, when a child shows severe regression, ataxia, or motor instability, intellectual disability, and drug-resistant seizures, it's important to consider metabolic and genetic testing. Early diagnosis and treatment can help prevent irreversible cognitive damage and can significantly improve cognition, seizure control, walking ability, and language skills, ultimately giving children a better quality of life. 2. The struggles of adult sisters with CFDS. Now let's take a look at the case of two adult sisters with CFDS. Their story highlights how CFDS in adults is often not diagnosed in childhood, leading to delays in treatment. While symptoms may stabilize in adulthood, treatment can still effectively reduce seizures and improve cognitive function. The older sister's story. The older sister had a completely normal early development, but at 22 months, she began to experience myoclonic seizures, ataxia, and developmental regression. By age 15, she had learned about 75 to 100 words, but by 30, only 12 words remained. By 7 years old, she had become fully wheelchair dependent, losing most of her motor abilities. While her seizures improved between ages 11 to 18, in her 20s, generalized tonic-clonic seizures returned, especially during sleep. As an adult, she now experiences about 1 seizure per day and takes gabapentin to manage them. The younger sister's story. The younger sister's condition was even more severe. She had a normal development until about 18 months, when she started to show progressive ataxia and developmental regression. Her condition quickly progressed to myoclonic seizures, which eventually developed into generalized tonic-clonic seizures. She also had severe feeding difficulties and became fully wheelchair-dependent by age 5. Though she learned a small number of words, her cognitive development showed almost no progress. In her 20s, her motor abilities continued to decline, and her seizures remained frequent. The challenging diagnostic journey. The diagnostic process for both sisters was particularly challenging. Their symptoms didn't fit a typical pattern and gradually worsened over time. Finally, genetic testing revealed both sisters had a homozygous mutation in the FOLR1 gene, which caused impaired folate transport to the brain and disrupted neurodevelopment and brain function. Further cerebrospinal fluid analysis confirmed that their 5-MTHF levels were significantly lower than normal, confirming the diagnosis of FOLR1-related cerebral folate transport deficiency, FOLR1, CFDS. The treatment journey. Once diagnosed, both sisters began treatment with calcium folinate, Leucovorin. After starting treatment, their seizure frequency significantly reduced. The older sister's seizures decreased from 20 per month to 13, and the younger sister's from 42 per month to 20. As their seizures became more controlled, both were able to reduce their anticonvulsant medication. Improvement in psychiatric symptoms. Folate plays a crucial role in the brain, especially in the synthesis and repair of neurotransmitters. 5-MTHF is the most important active form of folate in the brain. Calcium folinate, as a precursor to 5-MTHF, does not rely on folate receptors, allowing it to directly enter the brain and provide the necessary folate. This treatment can improve brain function, alleviate seizure symptoms, and enhance both cognitive and motor abilities. The importance of early diagnosis. This case of the adult sister serves as another reminder that CFDS, though rare, shares symptoms with many common neuropsychiatric disorders, making it easy to misdiagnose. Early diagnosis is critical to prevent further neurological degeneration. With genetic metabolic testing and timely treatment with leucovorin calcium, folinic acid, patients can experience significant improvements. This case highlights the importance of early diagnosis for those with metabolic psychiatric disorders, helping patients live fuller, healthier lives. Closing thoughts. Cerebral Folate Deficiency Syndrome. CFDS is a complex condition that presents many challenges for both patients and their families. But with early diagnosis and treatment, many patients can see significant improvements and regain hope. Whether it's developmental delays in childhood or seizure recurrence in adulthood, timely treatment with calcium folinate can be life-changing. As the medical community continues to explore metabolic and genetic-based treatments for these types of neuropsychiatric disorders, we're paving the way for more effective care. By helping more patients find the right diagnosis and treatment, we can give them the chance to overcome their struggles and embrace a better. If you're interested in stories about genetic metabolic disorders, IEMS, and their connection to mental health, what we call metabolic mental disorders, don't forget to like, subscribe, and share this video with anyone who might need to see it.